Sounds good. So again, I'm a public healthcare attending at the University of Florida. Most recently, I went on a humanitarian mission to Gaza for 2 weeks. And to me, it was an eye opener. So this is a grand round, so it's a medical grand round. So we'll try to keep it medical and try to present my experience there with ultrasound, all the stories, or maybe tell maybe part of the story through ultrasound. So I called the grand round "Echoes of Compassion: Ultrasound Use in Gaza Crisis." The cover picture that I have here was actually chosen as the World Press Photo of the Year. So a mother that's, I mean, the picture is filling probably 1,000 words there. So this mom was basically grabbing her child who's coughing. The presentation focused on medical application of ultrasound technology in Gaza during the assault, drawing from the speaker's observations during their mission from on March 25th. It may not encompass all the facets of the crisis in Gaza, and my presentation might have some graphic medical pictures. Tomorrow, I have a presentation in the library on University Avenue, just covering different aspects of the story, maybe to light more on the humanitarian side of the story. And I will be joined with a couple of my colleagues, Dr. Ahmed, who's an anesthesiologist in Fort Lauderdale, and Rana, who's an ICU nurse and who joined us from Tampa. She's been to Gaza 2 times now, and she will be joining us tomorrow also to be part of telling the story in this report back. If you have time, if you are interested, please don't hesitate to join us. Just a couple, just small brief background. There has been an almost complete blocking of essential medical supplies and medicines to Gaza. There has been an ongoing bombing, direct invasion of almost all the hospitals and the other medical facilities, killing, targeting of healthcare staff, and targeting ambulances. And this comes against a halt of crucial services, including electricity, food, water, fuel to Gaza, and displacement of over 2 million people. I took this from a report by Al Jazeera, but I'm here to tell what I've seen as part of this story. So while we were in Gaza, the kitchen aid workers, I remember the kitchen aid workers were targeted, and like it was all over the media. I mean, CNN, Fox News, everywhere. But during our time in Gaza, I had the chance to talk to a lot of healthcare workers, a lot of paramedics, and a couple of officials as well at the European hospital. And they told us that more than 200 ambulances have been directly targeted and didn't take the media attention that happened to the kitchen aid workers. The other part of the crisis there is that the whole community, you're talking about 2 million people, were basically in true hunger. And some parts of Gaza actually famine applies. For that reason, part of our mission there was actually just the humanitarian aspect. So in this video, we were basically distributing food to children and people on the street, and you can see that they were desperate to get some. To make a couple of these usually costs $50. It did cost me $700 to make a couple of these. That has a little bit of chicken, a little bit of potatoes and broth, basically, and I couldn't believe it until I've seen it and witnessed it firsthand, which was difficult to believe. So I decided to show this just to give a little bit of context of where exactly and how exactly we were practicing there. So this is the most prestigious hospital in Gaza before the assault. It's called the Shifa Hospital. It's the Shifa means healing. So this hospital symbolizes healing. Just a couple of months before the assault, it had a new interventional radiology suite. It had 700 beds, had specialties of all different specialties. And there were claims that it was used for other purposes. And then this is the result of that. So you can see the whole hospital destroyed. This happened while we were in Gaza. I wasn't near the Shifa hospital. I was probably 20 miles away from it. But we had a lot of refugees from the Shifa hospital area. So we had some nurses, we had some physicians, and other healthcare workers who were trained at the Shifa hospital, and I saw them all crying, and they were just when they saw these pictures, because they had a lot of memories. It did represent a symbol of hope and a symbol of resilience for them. And you are hearing the news these days about the bodies that they are finding in the grounds around the hospital these days. So this is part of the story. I showed this picture because this is part of the story. Because a lot of the healthcare workers that I worked with were actually volunteers. So they were volunteering refugees from the Shifa hospital. Because when we first entered Gaza, we entered through the Rafah border after driving for probably 7-8 hours from Cairo to Gaza. We were 12, probably 10 men and 2 women. We had Amani, Rana, we had Mark, Perlmutter, Fairuz, myself, Walid, and a few other surgeons. And my friend, he was also a pulmonary critical care attending. So we were tag teaming and covering the ICU together. Mark Perlmutter was an orthopedic surgeon. Fairuz and Amir were trauma, and Muhammad were trauma surgeons. And we had a couple of thoracic surgeons and a neurosurgeon. It was mainly a surgical mission with a couple of medical people and a couple of nurses. So just again, to give some context about where we were. So you can see that the majority of Gaza Strip, which was inhabited by 2 million people, has been actually destroyed, starting from the north to the middle. So a lot of these people were actually displaced to Rafah city. So Rafah has probably 1.5 million displaced people. The rest of the Gazans are north of this, or north of the Gaza valleys. So this city normally has 200,000 people, but now it has 1.5 million people staying in it. So you can imagine the amount of pressure this puts on the infrastructure. Our hospital was actually here in Khan Yunis, which was a city of ghosts, by the way, because it was completely empty of its civilians. And except for our European hospital area, which was actually close to the border, but has not been targeted, or it has been targeted, but the hospital itself hasn't been targeted directly. So again, you can see that normally Gaza is mostly populated in this area, because you can see, like in the south, there are only 3 hospitals. So there's the European hospital where we were practicing. It originally has 220 beds. It's a specialty hospital. But now it was operating at a capacity of like 1,000 people or so. There's the Kuwaiti hospital and the Nasser hospital. Nasser is a little bit bigger than the European hospital, but this also has been directly invaded and bombed and burned to the ground, so it's not functional anymore. So the only technical and practically functioning hospital from here all the way here is actually the European hospital, and there's another small hospital which is hidden here, the Shuhada hospital, which is a very small hospital. So our trip was extremely tiring. We were staying in this room. I was staying in this room, which has, it's probably from here to here. And we had like 6 mattresses back to back, sleeping in that room. And our sleep was very much interrupted for many reasons. Because there was bombing around probably 5 or 6 miles away. And whenever a bomb hits, it kind of shakes the ground. So the walls of the hospital was actually shaking. And it easily can wake you up. There were drones that fly in the sky the whole time, especially at night, and they have humming voice, like you can hear the humming voice. So we were, any chance we get to sleep, even while sitting up, we would take that chance. This is the European hospital, just to give some context. So this is the European hospital before the war. You can see
وقصر البرش نفسي وبفضي قلبي بالموت والمشي.
So it was a clean, beautiful hospital. It had, again, I'm saying this because the residents actually that were on the hospital were apologizing to me at the time. I'm going to show you the difference. So you can see clean hallways, clean rooms, the lights were beautiful. This is the neurosurgery center. This is the ICU. This is on a normal day. This was taken by a resident for the ICU. This is the ICU where the main ICU had like probably 14 beds. So this was taken by one of the residents before the war, and it was an example of cleanliness and highly functioning hospital. This is when I first entered the European hospital. I was writing my diary, so I wrote like a chapter about, I called it Judgment Day. It felt to me like Judgment Day because you can see here this is inside the hospital.
As you can see, refugees are living inside the hospital. All the refugees sleeping inside the hospital, which is putting a lot of pressure on the system. The system is struggling. People are very smart here, they are very hardworking. You can see they are very patient. They are handling stress very well, as best as they could. But the system is struggling. You can see that the youth is living inside the hospital. So, when working on and last year, and I think very cool. So that is all about the وهذا يضع ضغط
Speaking in native language.
الصرف الصحي
So this was just a regular walk. I was working with these two officials to deliver the ultrasound machines. I brought a couple of ultrasound machines with me, so I was trying to work with them to give it to them in their office. And this just keeps going. It was everywhere. Like behind each blanket is a story of suffering and a story of missing. This is inside the hospital. Like you are walking to the ICU. This is what we see all day long. Okay, so I just wanted to show these pictures for some context, because this was part of our problem there. The infection control was impossible. You can see here there was a school right next to the hospital, and it was turned into a refugee place. You can see this is the entrance to the ICU, and people were literally sleeping here, like living here. And the reason why they seek refuge inside the hospital, because in their minds, it's presumed to be a safe place, but that wasn't proven to be the case in other hospitals, unfortunately. So while you are walking the ICU, you are literally, you can step on someone's foot because they are sleeping in the middle of the hall. This is the Shifa hospital, and it actually had the same situation before the second invasion. So there was like the European hospital had 15,000 refugees on its grounds, in the hallways and in its grounds outside. The Shifa hospital had what's estimated between 50 to 70,000. It was a bigger campus. So before the invasion, the same picture that you saw in the European hospital, the people were having tents and they were living inside all of these hallways when the second invasion happened. So this is the case, unfortunately, after that. You can see this kid here. This is Mark Perlmutter. Again, he's an orthopedic surgeon. You can see this kid. He's not looking at him. He's looking at the water. Okay. We brought some water with us from Egypt, and we used it for our personal use. And he was grabbing this with him to the OR because he's going to spend the whole day in the OR. He didn't hide it. So whenever I grab a bottle of water, kids like him would follow me and they say, "Can you give me some water?" Because they do have water, but it's not as clean as this. Like when I was washing, we as a mission workers, we had access to, we were like 40 people for 2 bathrooms because we were treated as a mission. And the water that when we wash our faces, it was salty. So it wasn't as clean as this. So the kid is just looking here and he's telling him that it's my, this is, I'm sorry, I can't give it to you. He didn't speak Arabic, so maybe he gave him some, I'm not sure. The other problem that we had was sewage. So you can see that this street is right, like this is the entrance to the hospital. You could see on the previous video how clean the hospital was, and now we have all of these sewage, and we had a lot of flies that would come here, fly all the way, go inside the ICU, and they will land with the burn children and burn kids. So infection control was almost impossible. I'm trained to take care of adult patients in the medical ICU. So when I went, and I was expecting to see a lot of adults, with in their middle age, with a lot of traumas, orthopedic traumas, injuries, etc. But what I was dealing with, and literally what I was dealing with, were actually children. So half of the patients in the ICU were like this kid. Unfortunately, had 40% body burn because of explosive injury. He ended up dying of sepsis. This had 20% body burn. He ended up dying of sepsis. This kid actually touched my heart. I took care of him for almost a week, and all of his family were killed. You can see his name. Like parents, they have a habit there of writing their children's name on their bodies, just in case there was a targeting or there was a bombing, so that people would know them. So he had his name here, and he had a deep cut wound and shrapnel inside his brain with traumatic brain injury. Unfortunately, I was hoping for him to survive. He was the only survivor of his family. We treated him for like a week, but he again ended up dying of sepsis. Another interesting case is like I saw some cases like this one. So this is like probably some cluster bombs, or I don't know. It was very weird. Every time you try to patch a hole or you try to fix somewhere, you find some infection somewhere else. So this patient also ended up dying because of trauma. Despite all of these, and this was just a glimpse. I did intentionally hide a lot of very graphic pictures, so I decided to hide all of that. But this is a picture of the group of residents that we were working with. This is my friend, who is pulmonary critical care attendant, and this is myself. And these are a group of residents. Now, the reason why I titled this picture as resilience, you probably wouldn't, I don't know if anyone of you would notice, but there is the picture of this guy who's here on the wall. So I couldn't but notice this picture because this picture was everywhere. So I asked the kids, the residents, about this guy, what's his story? And they told me that he was actually a fifth-year anesthesia resident. He was their senior. And a few days into the war, him and all of his family were bombed. So he was killed, all of his family were killed, except for his daughter, who was a 3-year-old, and she survived. Like I said, that she was 20 meters away from the explosion, completely healthy, and she's living with a distant relative right now, unfortunately. His name is Tanner. Every one of these folks actually has a story. This guy is a refugee from the Shifa hospital. He's from the north. When the invasion happened, he had to leave with his scrub and his wife. His wife just gave birth like a month ago in tent. And you can imagine the difficulties that he's going through. Like to the extent where when I give them my luggage bag, that was like a treasure for them. Because they left without nothing. This one, his brother was bombed on a previous incident, 2018. And then his sister-in-law had 2 children from his brother. She ended up marrying the other brother who was killed in this war. And she has another 2 children from him. So she's a woman. She has 2 orphans from the first father, 2 orphans from the second father. He was still here. This guy is also a refugee from the north. He was staying with us the whole time because he's technically living in the hospital. I don't remember the story of this gentleman. This guy is a refugee from the Indonesian hospital, and he is a refugee from the Shifa hospital. So every one of them, when you talk to them, and I'll tell some of their stories tomorrow in the library. Anyways, so ultrasound. One of the attendings, one of my love mentors, when I was chatting with him, he was trying to give me some tips, and he told me that, if you want to join academic medicine and you want to shine, you want to succeed, you have to pick a niche, especially in pulmonary care. You have to pick a niche such as ILD, pulmonary hypertension, interventional pulmonary cystic fibrosis, or any other major pulmonary branch. But to go wandering around with an ultrasound probe that won't flourish in academic setting. That was my friend's words. The problem is, when I first joined fellowship, I loved pulmonary hypertension. I wanted to do pulmonary hypertension, but then I worked with Mike Jans. I spent like a lot of time with him. So I did end up loving interventional pulmonary. And then you spend time with Farouk, I ended up loving interstitial lung disease. So I did love, I did enjoy actually working with all of that. And, probably for other reasons and contextual circumstances, I didn't pick any of these fields. But I did get my board in ultrasound, and I tried to focus my time, investing some time in doing some ultrasound, publishing some papers in ultrasound. So fast forward to Gaza, I think that proved to be extremely helpful. When we were in the ICU over there, the chest X-ray, there's no such a thing as a stat chest X-ray. So your patient is getting hypoxic, or you get a central line, you order a chest X-ray, it doesn't happen. You have to wait for next day for it to come. We didn't have ABGs for 10 days. Why is that? We did bring an iStat with us, but the Egyptian border decided to confiscate that. So they didn't allow that inside. So we didn't have ABGs. So we had a lot of the DKA patients that we were just managing based on smell, based on the volume status, and based on your best clinical judgment. CT scanners, the CT scanner was actually functioning, but it functions a day and it's broken for 2 days. It functions a day, it's broken for 2 days. Plus, there's a lot of pressure on it because of too much trauma cases. So there were a lot of trauma cases. For that reason, I did grab a couple of ultrasound machines with me. One of them, 2 linear probes and 2 the phased array probes with 2 tablets, the ones that you guys use at the VA hospital, the Cosmos ultrasound. So I did bring, and luckily, they were not confiscated at the border. So I was able to take them in. And I told the residents, I'm going to wander around with the ultrasounding everyone while we're in the ICU. So it did prove to be extremely helpful in that scenario. And I did show this slide before that you can see that lung ultrasound critically ill patients, it does have a really very decent sensitivity and specificity for pleural effusion, alveolar consolidation, interstitial syndrome, complete pneumothorax. For occult pneumothorax, it might be a little bit tricky, but if you do your due diligence, you'll be able to capture it. And I did share this slide with you before, where the time to making a diagnosis when performing history and physical vital signs, physical exam, EKG, and then randomizing the patients to ultrasound versus the classic route of just X-ray, TTE, CT, and other labs, the time to making a diagnosis was 24 minutes as compared to 186 minutes. And this did prove to be very true in Gaza. So just to make it a little bit interactive so that we can hear some comments from the fellows. Ephraim, what do you think we're looking at here?
Is this like lung evaluating for pneumothorax?
Okay. Perfect. So what does this tell you? So sandy beach means that there is?
It's normal.
There is lung, exactly. So there is lung sliding. So the sandy beach pattern, which is M mode, which tells you motion, that it tells you that there is lung sliding. You can see the lung sliding in this picture as well. What about here, Ramina?
It's a barcode sign.
Oh, before you go, so what is this?
Oh. So on the left.
Yeah.
In the left picture, those are A lines.
Perfect.
So that is like replication of like the normal shadow of like.
Exactly. So it's a reverberation artifact. So it's a reverberation artifact. So this is the plural line. You have a line here, A line here, A line. Okay. What do we see on the right side?
That's a barcode sign.
Okay. And what does that indicate?
That indicates that there is a.
Okay.
Or at least there is no pleural sliding at the point where you are
Exactly.
measuring.
So what can give you this picture?
One would be pneumothorax.
Okay.
I don't know if you would also see that in areas where like there's significant adhesions around the.
Okay. Like as ARDS, right? What about right main intubation? Right main intubation, you have absent lung sliding on the left side, right? So basically, this doesn't tell you that there's pneumothorax. All it tells you is that there is no lung sliding. Okay. And in the right context, for example, we had a case in Gaza where the resident placed a subclavian line, and then a couple of hours later, the patient was getting hypoxic with the ventilator changes. We did that. There was a barcode sign, and it was a diagnosis of pneumothorax. So in the right context, it can mean pneumothorax. So what do we see here? Another example of lung ultrasound. You can see that there are some B lines here, and whenever we see B lines, this means that there is no pneumothorax. And if you see more than 3 B lines, this can tell you that there's an interstitial pattern. There's an interstitial pattern, which could be pulmonary edema, ARDS, or pneumonia. You can see a thick B line in this slide over here, right? Over here, again, you see the sandy beach pattern, which tells you that there is lung sliding. And over here, there was also, again, demonstration of lung sliding. Maybe it was a little bit poor, but there was some lung sliding, which can technically, you can say that there is a pneumothorax in the right context. Now, in this slide, what do we see here? Kai.
That looks like lung point.
Exactly. So this guy actually had, there was a drone that floats around in the neighborhood. It's called quadcopter. And I don't know, it does have some sort, it's like self-driven. It does have some sort of AI or something like that. So it does shoot the patients with very random places. So they come to you with spine injury, abdominal injury, head injury, based on certain algorithms that it had. So this guy was a victim of quadcopter, and we were able to make a diagnosis of pneumothorax based on the lung point. So for the fellows, lung point is actually the only specific sign for pneumothorax on ultrasound. So if you see a lung point, we can make a diagnosis of ultrasound. Over here, we were kind of shifting, but you can see that there is some lung point, which is basically the transition point between pneumothorax and the normal. If Swami is with us, I think he's taking the exam now. We were able to locate, to know exactly where to put the chest tube if you look carefully until you find the lung point. Again, this is just to emphasize what I said. So lung sliding indicates that there's inspiratory descent of the lung, visceral pleural line, and expiratory ascent. M mode is the motion mode. So basically, you can see, if you put an M mode, it shows the sandy beach here, which tells you that there is lung sliding. Your hand must be motionless. Although I have to say, because the motion here, this is what does this part demonstrate? Soft tissue, right? So skin and soft. This is skin, soft tissue. This is the pleural line. So basically, this happens because of the difference, the contrast between the relatively static soft tissue and the motion lung tissue. And to me, to be honest with you, I struggled with Gaza's patients because all of them, they didn't have fat. Like the average BMI here is like 35, 40. The average BMI there's like 17, I would say, easy. So they didn't have, all of them were like just very thin muscular layer. So the pictures that I had to increase the depth a lot to be able to show the classic pictures that we have.
That portion with the subcutaneous tissue, what does it look like if they have a subcutaneous emphysema? Do you know if there's like?
It varies, but you might start seeing some A-lines depending how severe it is. Yeah, the same thing, you can see A-lines in the abdomen. If you have air in the abdomen, you will see some A-lines. Now, I need to bring it to your attention that we just released this issue in Critical Care Medicine, which is the 4th issue of JAPA Journal. And we have Haneen, who published this beautiful review article about utilizing point-of-care ultrasound for ventilation reparation, a state-of-the-art narrative review. And this issue is dedicated for critical care medicine. It does have, it's all written by experts in the field in different aspects. I will share it with you in the ultrasound group, just to bring it to your attention. All right, what are we looking at here? If you have to guess.
Like the stomach, that's the liver, I see a liver.
Perfect. So we're doing a fast exam.
Like a fast in the fast.
This is a fast exam, exactly. So this is probably the liver here. You can see the hepatic vessels. What is this?
Kidney.
It's the kidney. Okay. And what's important in the setting of trauma? What are we looking at here? What is this? Spine. Okay. So if there's a pleural effusion, you will see a spine sign that goes above the diaphragm, right? And what's important in the setting of trauma is to look for fluid here in the Morrison's pattern, right? Because if someone is laying flat, that's the most dependent part, and that's where the fluid will accumulate. So we were doing fast exam right and left in all the patients, and we managed to capture some positive cases. So this is, you start with the right upper quadrant where you look for the liver, you move to the spleen, you move to the subcostal subxiphoid area, which I didn't put in this slide, and then you go to the left upper quadrant looking for the splenorenal recess, which is also another spot for fluid to accumulate. And then what are we looking at here?
Bladder.
Okay, what is this inside the bladder?
Foley.
Catheter. Perfect. Yeah, so that's the bladder, right? And that's the Foley catheter, and behind the bladder is either the uterus or the rectum. So this is called the Douglas pouch or the uterovesical pouch. And that's another area of the patient sitting upright. That's where the fluid will accumulate. So after finishing all 3 spots, you look for the suprapubic area, and you have your ultrasound has to be sitting on the symphysis pubis. So it has to be right above the symphysis pubis. And we did manage to help a couple of anuric patients over there. One of them had obstructed a Foley catheter that was dysfunctional, was actually inflated in the urethra. So they were not, she was anuric, and we just replaced the Foley, and we were able to fix the problem. And the second patient, it was a false track Foley, so we ended up doing a suprapubic catheter, and that also helped him start puberty. This is for you for the fellows, because unfortunately we did lose a couple of dedicated slots for ultrasound didactics because of meetings and stuff. So I just wanted to show you the slide. So whenever you examine the kidney, these are the major calyces, these are the minor calyces, this is the renal sinus, this is the medullary pyramid, and the renal cortex, basically. So if you see hydronephrosis, this area will become anechoic, it will become black. And we had a case. So let me tell you, in the ICU over there, we had a mix, a lot of traumas, a lot of children with traumas. We had a lot of DKAs because people in the tent didn't have access to refrigerator or electricity. So they would come with they use just insulin that doesn't work basically, or they didn't have the insulin. So we had a lot of DKAs, and we had just regular medical cases of sepsis, septic shock, and then we had hepatitis A. During my career before going to Gaza, I've never treated hepatitis A. Over there, I had probably 5 cases. 3 of them were pregnant with fulminant liver failure. So one of these cases, we actually diagnosed hydronephrosis because she just had an intrauterine fetal demise, and the contracted uterus was compressing the ureter. So we were able to diagnose hydronephrosis using the ultrasound. Okay, this might be a little bit advanced, so maybe Kyle will be able to, and because I gave this talk last year. So let's see, Kyle, what do you think? Look at this. Let me repeat it again.
I think I saw pericardial effusion.
Perfect. So what kind of view is this? What view is this?
This was a costal.
Okay.
Subxiphoid view.
Perfect. So this subxiphoid view, this is the liver. You can see that there's a lot of pericardial effusion, right?
Yeah, I think you may see right atrial collapse and maybe RV free wall collapse.
Okay, so look careful at the right atrium. It's a little bit difficult to say whether there was collapse. I did think, as you did, that there is right ventricular and right atrial collapse, but you have to confirm that with other views. So let's look at here. What do you think? This is for the same patient. What are we looking at?
You're looking at the IVC.
So what's happening with IVC?
IVC is, oh, it's collapsing.
Collapse. Okay.
So that's a pretty good indicator you're probably not having.
Excellent. Excellent. So it's difficult to build a case for tamponade if you don't have, if the IVC is collapsed. It is difficult to build a case for tamponade. Okay. And the other thing that we did, you can do Doppler markup of the mitral valve and the tricuspid valve, and you look for the variation, the filling pattern. So between the left atrium and the left ventricle. So if there is more than 35% variation on the mitral side, more than 60% variation on the tricuspid side, this tells you that there is a Doppler pulsus paradoxus, right, which indicates tamponade. In this patient, he didn't have that. It was again another case of traumatic. He had, I think, traumatic brain injury, and he also had some shrapnels in his body. So we saw this effusion, and I thought that I touched base. We had one of the thoracic surgeons. I asked him whether or not he wants to operate on him, and he said that it's not indicated. If you can look for tamponade markers, which we did, and he said that I don't feel strongly about draining that. Okay, so just because, again, we're gonna skip the pericardial effusion talk this year because of Monday's meeting, faculty meeting. So the pericardium is usually there's a fibrous outer layer, serous inner layer, and usually it contains less than 50 cc of fluids. Usually it is difficult to assess thickness with echo, UNT, ECT, or cardiac MRI. The pericarditis isn't an echo diagnosis. However, I did have a kid who was probably 12-year-old. He came in with DKA. Again, it was difficult to manage him without ABGs, but he did complain of pleuritic chest pain with sitting up, and then I had to look. When we looked with ultrasound, did have pericardial effusion, which was 1 to 2 centimeters. So we ended up prescribing him. Unfortunately, there was no colchicine, there was no indomethacin. So we ended up just giving. I brought a lot of ibuprofen with me from the US. So we ended up giving him like 800 milligrams ibuprofen for pericarditis. Again, one of the things about pericardial effusion, it has to be present in systole and diastole, and it is important to use the descending aorta as a marker to differentiate, if you're looking at a parasternal long axis view, to differentiate between pericardial versus pleural effusion. There are many causes, obviously. In Gaza, probably trauma was the most common cause, but other causes you can have liver cirrhosis, volume overload, autoimmune. I had a lady with lupus that also had pleural and pericardial effusion. There is no immune suppressant medications there. Transplant patients, they have to pray, for their transplanted organs. So this lady had lupus. She didn't have access to her medications, so she had a lot of serositis, pleural and pericardial effusion that we did drain her pleural effusion in the emergency department. Whenever we evaluate pericardial effusion, look for the size. More than 2 centimeters is considered large. Look for the hemodynamic impact, the location, and the composition. What's her name? Afsana. We did have a case of hemopericardium and hemomediastinum that we were able also to catch with ultrasound. It's published in chest pictures. Again, the size matters. So anything more than 2 centimeters is considered large. Anything less than that is moderate, small, or trivial. You can see the pericardial effusion here. Anything anterior to the descending aorta is considered pericardial. Anything posterior to that is considered pleural effusion. again, as far as the echocardiographic signs of tamponade, so you have to have a dilated IVC with no collapse, exaggerated respirophasic transvalvular Doppler velocities. So you see some changes in the E2 variation, some septal shifting, swinging heart. The early signs that Kyle was trying to mention, inversion of the right atrium during late diastole and early systole, and RV chamber diastolic collapse. But beware, so patients who of Dr. Bryant, if they have pericardial effusion, they will not have collapse of their chambers because of the elevated pressures, which basically keep it open. All right, this is just to show some pictures. So we did have a lot of pleural effusion that we were able to capture and drain with whatever tools we had available there using the ultrasound. This is the liver, again, pleural effusion. I think this might be the spleen, this pleural effusion. Okay, so this trick, actually, I had the honor of learning this at the hands of the master, Dr. Caesar Trio, when I was a fellow, was a first year fellow. And then I did make it a habit to do it in any patients with encephalopathy. It did prove to be very helpful in Gaza. So what are we looking at?
The eyeball.
Exactly.
Yeah.
So we're doing an ophthalmic ultrasound, right?
Wow.
And this did prove to be helpful. So this lady, for example, Atta, so she did have hepatitis A, a fulminant liver failure with acute encephalopathy. So we were doing serial ultrasound of her eyeballs. So you can see, I think, this is the same patient. So you can see that it did increase. So basically the way you do it, you put on a lot of gel on the eyeball, and then with the linear probe, either using the ophthalmic configuration or just the vascular configuration is fine. You just keep fanning until you find the disc. You're looking for the optic disc. You go a little bit, maybe half a centimeter distal from the retinal base, and then you measure the diameter of the optic nerve sheath. You measure the diameter of the optic nerve sheath. Anything more than 6 millimeters is indicative of papilledema, basically, which can be evidence of increased intracranial pressure. So this lady, we were doing serial ophthalmic ultrasound. The good thing is, which when I was in Gaza, it was extremely frustrating. You see all of this death, you see all of this destruction, you see all of these children dying, all of these refugees, and we were literally not able to make a dent in the system. It was very difficult. The system was collapsing in front of our eyes. So that's why I tried to invest a lot in education. So every single night, it was Ramadan, so people were fasting. So just after they break their fasting, the trainees, we would sit in that room where you saw, and we were just spending like 2 hours, me and my friend, alternating 2 hours doing education, ultrasound, septic shock, and they were very thirsty for that, because they said 6 months we had no education. They were just residents on their own, They were probably experts in trauma. They can probably teach trauma to trauma surgeons here and trauma intensivists here, but they didn't have, any academic touch to it. So we tried to spend time to do some board review, do some education, and these pictures, a lot of them were actually taken by the residents. So this one was actually sent to me by the resident, and he said, "What do you think?" I told him, "Go ahead and give hypertonic saline," because they didn't have hypertonic saline. So I told them, go ahead and give hypertonic saline. So they were very thirsty, and they were, easy to teach, which was really good. I'm very proud of them, and I'm pretty sure that whoever's going to go to that unit in particular and keep working with them, they will become excellent using ultrasound. It wasn't part of their practice whatsoever using ultrasound in ICU before this. So this is just a couple of slides. I know we're becoming getting closer to the end of the talk, but again, optic nerve sheath diameter, you go half a centimeter behind the retina. The sensitivity and specificity varies. Some claim it's 90%. Some claim it's as low as 70%. Regardless, in Gaza, we have nothing. It's not as well just use it, and it was very helpful. And this is another study about optic nerve sheath diameter for specificity and sensitivity, and it was very helpful. One last thing, I didn't have any slides on it, but what are we looking at here? Exactly, DVT. So this is again for the same patient. So DVT here, so you look for collapsibility. There are some signs of DVT. The most important thing, if you are doing just a screening, is to look for a 4-point collapsibility screening, 2 points femoral, 2 points popliteal. You can rule out ultrasound with that. The message that I wanted to deliver for the fellows is that, just X-ray, CT, all of that's great, and your clinical skills, but ultrasound can prove to be extremely helpful, especially that it's easily, you can carry it. So if you become a master of that, you can be a moving radiologist, moving cardiologist, moving pulmonologist, intensivist, and you can use it for a lot of things. Can you imagine being on an airplane, you ultrasound in your pocket, someone's having chest pain, you throw a probe, there's a pneumothorax there, and all of a sudden you are just saving that patient's life. That can be like a once in a lifetime story. Okay, I do encourage everyone. Yeah, so this is just, I'm working on a case series to publish this. There might be a room for one, because I promised the folks over there to include 2 or 3 of them, but there might be a room for one from here. If anyone is interested to help, please jump on it. So just working on this case series about utilization of ultrasound. So this is a traumatic brain injury, how we end up diagnosing pneumothorax. You can see 16-year-old explosive injury with shrapnel in the mediastinum. We ended up diagnosing no pericardial effusion. There was no indication for surgery. Explosive injury, chest tube. This is for Khalid, the boy that I showed you. He was day 5 post-intubation, worsening hypoxia, had B profile, left collapse, C1. We ended up diuresing him, ventilator adjustment, and proning him. Unfortunately, I'm not an expert in pediatric ICU, so that's the best I could do. But unfortunately, he ended up dying because of sepsis. I'm pretty sure if there is an infectious disease specialist that goes there with capacity for like some, lab capacity, I'm pretty sure they have bugs there that are unique. Something that only wards can produce. Like something that of mycobacterium or something that's in Gaza soil after all. You can smell the gunpowder. You can smell the dust in the air. So I'm pretty sure there's something there that we were not capturing, because we were treating these patients with vancomycin, meropenem. We were adding fluconazole. We did bring some of these medications with us, and it wasn't budging. It wasn't helping. We are adding amikacin. So I'm pretty sure if someone is interested,
It's melioidosis, the classic chopper disease.
Yeah.
Vietnam.
Yeah.
So they lift up the dust and they inhale it.
Yeah. So yeah, I'm sure something was there. I'm not an expert in mycobacterium or more pathogens, but this can be a huge area for research for mission workers who are interested to be there. A lot of pregnant women, a lot of traumatic brain injuries, and we were able to utilize ultrasound to make a difference. What caught my eyes about the Gazans there, they are like these residents, like some of them lost their fathers, some of them lost their brothers, some of them, there was a neurosurgeon resident who lost his fiancé. He was fixing to get married. And despite all of that, it was very, I don't know, I couldn't understand it. They were showing up to work every day. There were like refugees from the Indonesian hospital who were actually held captive for 24 days under interrogation. They were like interrogated, who did you treat? Where were you on October 7? Which patients did you treat? Under all of that. And they were still showing up to work. I did hear stories from independent parties, like from the Indonesian hospital. And I did write a chapter about that in Arabic. So, and these stories were like independently verified. So you will hear the same story from 3 nurses. You'll hear it from a couple of physicians. You'll hear it from a couple of trainees. All of them tell you the story, how the Indonesian hospital was invaded and how they had to evict and all of that. And despite that, they were still showing up to work. So I do think that with hardship, there will be relief. Thanks so much. And I encourage you to be there tomorrow at the library if you are interested to hear more stories and see more pictures. Thank you so much. Any questions?